John Canalopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center, Clinical Professor of Ophthalmology at NYU Medical School in New York City, New York. A case very familiar for us. This is a almost 30-year-old graft done in Russia, in Moscow. You can see the gaping of the inferior part of the donor cornea, more prominent here, because of wound dehiscence between the host cornea inferiorly and the donor superiorly, because the patient didn't change his habits, eye rubbing during sleep. We can see here the tremendous amount of stigmatism. Unfortunately, we've seen colleagues doing laser on these eyes. The cell count is right on the top, is decent, very decent for 30 years out. And this is the OCT showing good cornea thickness. We can see it here on the Avanti Optiv OCT lines where the cornea has stretched out, and it's because of eye rubbing. And we're going to the OR. We're going to do our Athens technique here using a 15 knife, 15 angle knife. And this is very difficult to do because you want to go as deep as enough, but not to perforate through. And you want to reopen the wound because you want to separate the donor from the host as much as possible. Obviously, this is accelerated times 8. And we're measuring here to see what the graft was. We're starting to place riboflavin solution within the graft-host interface, so you figure it out. We're going to follow with higher fluence cross-linking 30 milliwatts per centimeter square for a total of 6 minutes. And here we go with our old suturing skills taught to me by Eric Donenfeld, Hank Perry in New York, and the late Klaus Doman in Massachusetts, Boston. And this really is similar to a cornea graft. You can see that we're able to go deep, very deep, almost at Descemet's membrane, mobilize the graft as if it was a DALC graft, and then go and resuture in order to reconstitute the graft-host interface opposition. And there's really nothing fancy from here on. It's just that we've been discussing this in meetings. We've published on this. We know that keratoconus is a product of hereditary predisposition that also needs a second ingredient, which is eye rubbing. We thought that eye rubbing is most important during the day, but it appears that it is worst at night. So invariably, if you ask your patients how do they sleep at night, if they don't know, it's a good idea to tape it, even in a time-lapse form. You will not be surprised to find out that they sleep face down, usually on the eye that's more involved. If both eyes are involved, they alternate eyes. Sometimes they rub their eyes sleeping face down under the pillow. We're continuing here the interrupted sutures. Obviously, it's very important in the Boston technique to go deep, almost flush with Descemet's both on the donor and the host. And again, I would certainly not regraft this patient, taking into consideration that the endothelial cell count 30 years out at over 1,000 is remarkable. So this was a job very well done in Russia. I'm not sure if it was Fyodorov himself or one of his cornea transplant in his team. This patient had traveled from Cyprus to Russia at the time to undergo a cornea transplant. We're burying the knots. Very important to cross and square your knots. Make them tight, 3 passes, so that way they can be buried very well. And again, we're going to complete this procedure with 16 interrupted sutures. We're replenishing the riboflavin, the graft-host interface. You saw in the beginning that I placed some methylcellulose in the center of the cornea because that part, the central cornea, I'm not interested in cross-linking. We have the Pesky device. We're able to increase the treatment zone with the UV light to 10 millimeters, so surpass the diameter of the graft, which is 8 millimeters. And we will undergo a CXL procedure, an accelerated CXL procedure to cross-link just the interface. I'm going to, with her paracentesis, place some methylcellulose in the anterior chamber to bloat the chamber. I do not want to over-flatten this patient, so I'm playing around with the volumes of the anterior chamber. And also I want to protect the lens of the eye, which we can see has started to have some mild cataract changes, but not that significant. We know that our patient is currently born in 78, is in his 50s, and if you consider the corneal transplantation and all the corticosteroid drops used, it's not a remarkable finding to realize that he's starting to develop some cataract, and that can be used, of course, at a later time to also attain a metropia once all this has taken place. So we're continuing our suturing here. Nothing really exciting. I was talking about eye rubbing and keratoconus and how treating keratoconus, and you know that our go-to procedure is the Athens Protocol CXL with a topography guided normalization of the cone combined with accelerated CXL 6 milliwatts per centimeter square for 15 minutes. In this particular case, we used 30 milliwatts for a total of 6 minutes, so energy over 10 joules in total. We're burying the knots, used our last portion of riboflavin solution, and then methylcellulose in the center, and here we go with our Prisky device. The patient the next day is already 20/40. You can see the remarkable change from top to bottom, and on the left the change in the keratometry, him jumping to 20/40 from count fingers vision. A very helpful technique. Thank you so much for watching. John Canalopoulos signing out.